Great to see everyone. Welcome. Welcome.
I think that's everybody in, Roland.
Lovely. Good. Great to see you, Ginny, David. Great. Good. Hello, Francis. Hope you're well. Good. And Tony, is this the last of the current round of all staff briefings on priorities for the hospital? Is that right?
It is, yes. Yep, the last session in this series.
Great. Okay, good. Shall we make a start, do you think, Tony? Is that good? And Mike? Great. Good. Good afternoon, everyone. And welcome to the last of this series of briefings for all of our colleagues across CUH on priorities for the hospital at the moment. And I'm in my office looking out at the most dreadful weather, but I'm not letting myself get down about that. But it is a really particularly wet day for those of us who are all here in Cambridge. So thank you very much for joining. I'm going to talk through a little bit of the national context, how CUH is doing, and then Mike, you're going to talk through one of the major three themes for CUH for the next 1 to 3 years. And there'll definitely be a chance for people to ask questions at the end. And I may cold call on people. Nobody's been placed if we don't get any questions. And if we have time at the end, there's a quiz, which I know is something that is the reason we have 161 attendees here today. Right. So if we just start off with some opening remarks from me on the national context and where CUH is. So we've got a new government in power, elected at the beginning of the summer, and they have done two things. The first thing that they've done is to ask Lord Darcy to do a diagnostic of where the NHS sits. Let's look at the data, let's look at the facts, let's blow away the myths and the sort of the comments and get to what the data is telling us. And that's saying that the NHS is under really significant pressure, and that the capital investment in things like buildings and equipment and the revenue investment in managers, doctors, nurses, allied health professionals, and day-to-day equipment hasn't kept pace with demand. But alongside that, we've had patchy transformation, patchy change across the NHS. There's a lot of variation. And that's part of the reason we emerged from the pandemic weaker than other comparable countries. And it's why we're struggling to get back up to speed in the way we were before the pandemic. So that's thing number one. And then thing number two is the announcement of a new 10-year plan for the NHS, which will be developed for January of this year. And clearly, in the next 12 weeks, we're not going to develop a 10-year plan, but we are going to collectively lean into what do we think we're going to need to work on over that period. So that's the context that we're working in. And that, to be honest, has already crystallized, I think, for hospitals and health and care systems across the country. And many of you will have seen amazing progress, but also pressure at big comparable hospitals like King's in South London or Manchester or Newcastle, who are all doing amazing things, but also under quite a lot of pressure. And you'll also see some integrated care systems doing very well and others really struggling. And if you come and look at Cambridge, at CUH, at Addenbrooke's and the Rosie, what you can see on this page are a very similar range of areas of enormous success and areas of real pride. So just a screenshot, Tony, I think there of the article from the Times over the last 18 months, where we were talking about innovation and transformation with partners outside of the hospital and in the hospital in neurology. And that's the little picture in the middle with two colleagues, I think, on some sort of diagnostic device. So real progress and real success. We could be talking about developments in almost any part of the hospital where we're doing really good things. Those could be in corporate departments, they could be in patient-facing areas, and you'll know some of those. What you can see at the bottom of the page there is the opening of U Block, just between the Frank Lee and the main part of the hospital. And just next to that, you can see the design for the cancer hospital. And I think, as you all know, building on those in earnest will start in the beginning of 2026. we'll be doing ground clearance works on both sites, the Children's and the Cancer Hospital, as we go into the autumn, if the rain stops sometime soon, which I'm hoping for. What you can see on the right-hand side of the page, though, is areas where we've got really quite significant concern. We perform very well in terms of wait times for cancer and elective care, but our urgent and emergency care performance is significantly below what you would expect for an organisation facing the patients that we're facing with the assets that we've got. And we should be able to do better with what we've got. Okay, there's no excuse here. It's the system, it's patient demand. We're not doing as well as a hospital and as a system as we need to. What you can see in the middle of the page is when we went in the spring and looked under Lorraine's leadership as chief nurse at how we were doing in terms of core elements of care, the absolute essentials, we're not where we need to be. We have enormous variation in local leadership. The place is a bit dirty and grubby in places, and we've not got it quite right in terms of things like stores. Areas of real success from a Care Quality Commission point of view, but also areas where we're really quite concerned, and we're working on those very closely at the moment. And then what you'll see at the bottom of the page is staff engagement. So whilst colleagues here are saying to us, we would recommend this as a place to work, we would recommend this as a place to be treated, what that black line shows is that over 2 years, we've had a nearly 20% drop in people participating in the staff survey. And we've been going out to the organisation a lot over the last 3 months to team meetings. It was great to be in transplant for me the other day. I've been in the discharge team. I've been in urgent emergency care, day surgery, going to the neurocritical care unit. I could go on and on, just to hear from people why that's the case and what we need to do in my office and what needs to happen out there in the organisation. And as ever, it's sort of 50-50. So that's, if you like, where we are in that national context. And Tony, if we go to the next slide, you can see that what we've done over the last 6 months is listen a lot to you as members of the organisation. And we've talked to you a lot about what we're doing. I'm very grateful to many of you who've come back to us in the leadership community in the hospital to say that feels about right, or you need to change it. And to be very direct, if you haven't had that opportunity, do feel free to drop an email. I'd say I've relatively little sympathy with people who say, I've no idea what's going on and I'm not terribly interested. I don't think that's really well aligned with the trust values. And it's been great to be out in teams in the organisation, having that very robust back and forth as to what we both need to do to move things forward. So where we've got to through those series of engagements and series of conversations is a kind of refresh of what we're focusing on as an organisation. And we've been talking to you about that over September and into October. And this may sound like motherhood and apple pie, but it's not. There's a lot of things we're saying we're not going to do. But the 3 major areas of focus for us are, first of all, core elements of care, so quality, productivity, which Mike is going to talk about in a moment, along with quality, and flow in the organisation. And when we say productivity, it's how we use money to best effect so we can invest in the things we need to. And on flow, we're talking about making sure we're looking after the patients who aren't able to get in as well as those who are here. So that's number 1. Number 2, we're going back around what we're doing on culture, leadership and inclusion. And then a lot of work on new models of care, which will align very well with the new 10-year plan that's coming. And what I would say to you all before I hand on to Mike to talk about the first of those, we'll come back to you to talk about 2 and 3 in due course, is we're doing this to get ahead. We're doing this from a position of strength. We're not waiting to be put into special measures as we were in 2015. So us all leaning into this is going to be very important. And what you can see in the strapline or branding or statement on the right-hand side is that small things do make a very big difference. And that's very much the dialogue we've all been in some of those service areas that I've talked about, where the service will say we need A, B, and C. We'll say, what about C, D, and E? And then collectively, we think we can move forward. So Mike, I'll stop there, hand over to you. Do you think about questions as we hear from Mike about the first of those 3 themes? So Mike, over to you.
Thanks so much, Roland. Really good to see everyone. I am Mike. I'm the Chief Finance Officer at the Trust. Roland, I think I'm going to do similar to you, so that the kind of starting point for this conversation is to reflect on the strength that we have. And I think it's right to recognise that we've done really well on our financial performance over the last 4 years. We've delivered break even. That means that we've managed within our budgets for 4 years in a row. But I'd say more than that, we've also been able to invest as an organisation. So we saw some of the capacity investments that we've made across the campus over the last 2 to 4 years. But we've also invested in things like the package of support for staff in discounted food, travel, parking on site. And those things are really important and aligned to the good work agenda that we've got as an organisation. But I think for today, it's a moment of honesty and to signal that the position is shifting for us. We're seeing some warning signs that mean that NHS finances across the country as a whole are more fragile, but we're seeing that for CUH specifically as well. I think my overarching message is, if we don't act now, that our financial position will deteriorate and we won't be sustainable as an organisation. And what we're seeing is, when trusts haven't acted quickly enough, they do lead to positions where they're spending far more than they can afford to, with significant financial deficits. And what that means is that they lose local control. Turnaround directors get dropped in by NHS England. Decisions have to go through additional approval routes, to the point that any advert that goes out for a new member of staff would be subject to NHS England approval. And that's not a position we want to be in. And I've been talking to some colleagues who were around in 2015-16 and were here when we were going through a very similar financial turnaround period, and how difficult that was. So Roland, to your message, we want to get ahead and we want to maintain local control. So I guess the question is, what are the warning signs that I'm pointing to?
I'm joking.
Well, the first is on this slide, the headline message at the top there, that we are circa 7 million in deficit at month 4. Now, if you are very diligent and you look at our monthly finance reports, you wouldn't see that number, that 7 million. And that's because this year, as the previous slide signalled, we are using what's called our reserves to balance off the position, to deliver break even. The best way I describe that is to think of it like a household with a budget. So a certain income from jobs or other means, and certain level of outgoings from commitments for that household. We're currently like a household that's having to dip into its savings account in order to continue to pay the bills on a monthly basis. And just like a household, that's not sustainable. That savings account will run out. And therefore, we need to take action. We need to reflect on what we could do differently to manage within the resources that we've got. So what are some of the things that we can do? What I think the first thing I'd say is that we need to recognise the investment we've made as an organisation. The 4 really good years that we've had that have enabled us to invest in some of the things we've talked about. How can we leverage those skills, those assets to the best of our ability? And when I think about workforce, we grew by 8.4% as an organisation last year. That was in excess of some of our peer organisations. It is good investment to make, reflecting the capacity that we've got. But now we need to make best use of those skills, and we can't continue to grow. And I think my message would be, actually, I don't think we need to grow to deliver the services that we should be delivering for our patients. The second thing I'd highlight is that we all need to focus on what we're spending as an organisation. And it's not a task for just finance, it's a task for all of us to think about how we manage within the budgets that we've got. And this year we have a target for the organisation that we need to deliver 53 million of savings in year. But we also need to be working up the plans to deliver more than that as we enter the new financial year next year. And my request is, or my plea is, we need your help and input to deliver on that savings target for the organisation. And on this slide, you'll see in the bottom right some examples of some of the things that you need to focus on. Some of this will be quite transactional, so things like negotiating better contracts, huge opportunity, asking for discounts, pushing to get the best value possible. But actually, a lot of this will be delivered through how we deliver the care and services to our patients. And that's not just, again, about clinical teams, that's about all of us thinking about how we can deliver what is good for patients, but also good for our finances. And Roland, it's not an accident, I think I'd say, that we've grouped quality, productivity and flow together, those things I really believe will go hand in hand together. So Tony, next slide, if that's okay. Great. So in thinking about our patients and the services we provide, 3 particular areas of focus: reducing length of stay, ensuring our patients stay an appropriate length of time, but trying to reduce that as far as possible, increasing outpatient activity, doing more within the capacity that we've got as an organisation, and improving theatre utilisation. The next slide talks about the first 2 of those, length of stay or patient flow, and outpatients in particular. Next slide, Tony. So really good slide that summarises the set of things that we need to do as an organisation, and I'm sure this will be very familiar to colleagues across the organisation, and I think it's really well summarised by the headline at the top. So we need to make sure patients are in the right bed, cared for by the right team and discharged in a timely way. And then some examples of the sorts of things that we'll need to focus on discharge, looking to reduce the pressure on the emergency department. And we know things are really challenging, and we're in full capacity protocol at the moment. These actions are the things that are going to help us support the organisation in getting through those difficult periods, but also support the organisation in creating capacity to bring in more income for the organisation to deliver better care. Next slide, please. And then finally, outpatient services. I think we all recognise that the way we deliver outpatient services hasn't changed very much in the last 15 to 20 years. And our approach is to try and modernise and develop new models of care that are going to be fit for the future. So again, some examples on this slide of the sorts of things that we need to focus on. Leveraging on the work of getting it right first time, GIRFT programme nationally, patient-initiated follow-ups, using patient-not-present models. I just highlight one point though on this slide about recording of procedures. That's the second bullet point there. We looked at a clinic recently that only does procedures. And what we found is that 35% of the 100 patients we looked at in that clinic did not have their procedure recorded, yet we know that a procedure was done. The income that we generate for the organisation from doing those procedures is about twice the income that we get from a simple outpatient attendance. So we're doing the work, but not recognising and recording that we've done the work, and therefore not receiving what we should receive for it. So I say a series of examples on that slide of the way in which we are thinking about outpatient services. Next slide, Tony. And then finally, to wrap this all up, back to that campaign of small things, big difference. The question for all of us is, as part of our small things, big difference campaign, if you could change one thing today that would help us save money, save time, improve patient flow, or see patients in a different way, what would it be? And we're really keen to start a conversation around this. And we've got a story wall that you can link to via the Connect page. I think we'll put that in the chat as well. And we're really keen to hear some of your ideas. And as Roland said, we're really keen to have conversations. So as Roland has, I've visited a number of different areas. But if you'd like me to come and see what you're doing, I'd be really keen to come and see directly about the way in which you're delivering services and hear about some of the challenges that perhaps we can help unlock. I think that's it. Tony on the slides, I think. So Roland, I think we're probably moving into questions.
Great. Lovely, Mike. Thank you so much for that. Really very clear on the first of those 3 themes. And Tony, Mike, Judith, we're going to be returning to the senior leadership community and all staff as we go through the next 3 months with the other 2 themes to talk about where those are getting to.